Alright, so this morning's brief registrar presentation is on lumbar canal stenosis. So something that's a pretty common orthopaedic presentation, but probably something we deal with less these days since the neurosurgeons have started cutting in on a bit of turf and taking over a bit of spine surgery. So we'll just go through some of the basic principles. So, I mean, when you're talking about anything, any of these sorts of entities, you don't know what it is, and essentially the spinal column is made up of, well, the motion segments are made up of three main articulations. You've got your intervertebral discs and your facet joints, and those three joints together make up your motion segment. And essentially, canal stenosis, in a general sense, when we're talking about degenerative canal stenosis, begins as degeneration of the intervertebral discs. You then get abnormal loading through the facet joints. That abnormal loading then predisposes the facet joints to facet joint arthrosis. The facet joint arthrosis, in combination with the loss of disc height, gives you canal stenosis, which can be central, lateral or extraforaminal, and we'll talk about those sorts of the different classifications shortly. There's a general incidence of 1.7 to 8% in the general population, and symptoms typically develop in the 5th or 6th decade. So it's generally a degenerative process that we see in that age group that you see other osteoarthritic phenomena in. There's no sex predominance, so male and female are equally affected, except if you're talking about degenerative spondylolisthesis, which is 4 times more common in a female population than a male population. But purely talking about canal stenosis, it's an equal distribution amongst males versus females. You can classify it anatomically or you can classify it etiologically. Essentially, you can have central canal stenosis, which is compression of the dural sac and its contents, being the cauda equina. You can have lateral recess stenosis, which usually picks off the nerve root as it's exiting out. Or you can have extraforaminal stenosis, which is far lateral, which is normally taking the nerve root above. So, for example, in a lateral recess stenosis at L4-5, you're going to be getting the L5 nerve root, whereas if you've got far lateral or extraforaminal stenosis at the L4-5 level, you're going to be getting the L4 nerve root, and that's a particular, of particular relevance when you're dealing with this, so you can correlate your clinical signs and symptoms. It can also be congenital, acquired or combined. Probably the most common type of congenital is seen in the achondroplastic dwarf, who have a very short interpedicular distance and have a much higher incidence of lumbar canal stenosis at a much younger age. You can also have acquired, well, in addition to congenital, there is acquired, and in addition to the predominantly degenerative, which is mainly what we see, you can have it due to spondylolisthesis. It can be iatrogenic, so caused secondary to previous surgical intervention, or you can have a post-traumatic or any combination of these causing stenosis of the spinal canal. So the basic anatomy, so here's your spinal canal here, your vertebral disc or body, and here are your facet joints. So the things that contribute to spinal canal stenosis can be disc-based, so you can have a disc prolapse, bulge, or anything affecting the disc which can encroach on your canal. It can be due to facet joint pathology, so you get degenerative change, osteophyte formation, and that contributes to canal stenosis. And the ligamentum flavum, which is intimately associated with the lamina and with the facet joints, also becomes hypertrophied and quite thickened, and all of these three components contribute to canal stenosis, and depending on which is the predominant contributor, that will sort of dictate whether you've got a big central disc, which is giving you a central canal stenosis, whether you've got enlarged facet joints, which may be giving you lateral recess stenosis, or even further out here, giving you extraforaminal stenosis. The diagram on the left basically talks about the 3 most common anatomical configurations of the canal, being round, ovoid or trefoil. And trefoil canals have a higher association with canal stenosis because they have the narrowest canal diameter, and trefoil canals are also seen in the achondroplastic dwarf as well, which is one of the contributing factors to their high incidence of canal stenosis. So this is just an axial CT scan and a lateral X-ray showing some of the anatomical pathology we talked about before, and you can see here the osteoarthritic change at the facet joints with osteophyte formation here encroaching into the lateral recess. You can't quite see, but this is the canal here, and it's encroaching into the lateral recess of the canal. And you can see on this plain X-ray, you can see the nice wide patent foramen in the vertebral segments above, and you can see here between L3-4 this large amount of osteophytic narrowing within the foramen, causing the foraminal stenosis. So what's the pathology? Well, you can have a congenital predisposition, so any of us might have some sort of anatomical predisposition like a trefoil canal or a slightly narrowed spinal canal. But essentially the main, and we're talking predominantly about degenerative the degenerative canal stenosis here. It really starts with primarily as a disc problem. So you get disc dehydration, disc loss of height, and degenerative change through the disc. You get a bulge in the annulus fibrosus and ligamentum flavum, which starts to encroach on the spinal canal. The alterations through the disc cause an altered load at the facet joints. So if your disc's no longer taking the amount of load it was before, it puts an excessive amount of load on the facet joints. The facet joints then start to degenerate, and you get degeneration in all three components of the motion segment, which leads to progressive osteophyte formation, ligament hypertrophy, and stenosis from all of those three components. But why do we get symptoms? I mean, there are lots of patients who have quite severe canal stenosis on imaging who are completely asymptomatic, and there are lots of theories as to what the pathology behind symptomatology is. The main ones are that there can be direct compressive effects upon neural elements. Venous congestion and arterial constriction can cause ischemic phenomenon or engorgement of perineural tissues. This direct compression can also cause a blockage of the axoplasmic flow within the neural elements, which also predisposes that to becoming edematous. It causes a demyelinating phenomenon, which ultimately results in Wallerian degeneration. So whilst these etiologies are probably more associated with pain generation, further down here, this is where you can get your neurology. And once you start getting down to these bottom two phenomena, you're probably going to be looking at irreversible neurology, whether that be sensory or motor. Again, along the lines of the pain generation, like we said, a lot of patients come in, they'll review X-rayed all the 70-year-olds or CT scanned spines of a whole heap of 70-year-olds who are completely asymptomatic who came in to see you with knee arthritis. The vast majority would have some degree of canal stenosis and certainly degenerative change in the lumbar spine. So how do we pick which ones of those, which patients of these go on to become symptomatic? And again, there are a number of theories, but they focus predominantly on neural ischemia or congestion and substance P secretion. There have been a number of studies that have shown in patients with symptomatic canal stenosis, they have higher levels of substance P in that perineural area. And substance P has been shown to be secreted by the dorsal root ganglion as a very pro-inflammatory agent and causes quite a degree of perineural inflammation. And I think this is now thought to be one of the major pain generators in symptomatic canal stenosis. So that said, all the pathology behind us, what do we actually see? Well, 95% of patients who present with back pain, so axial back pain or possibly even buttock pain. There's also a significant proportion that present with claudication, and we'll talk about exactly what the definition of claudication is for some of the registrars and residents, because it's probably something we talk about with, neurogenic claudication, but I don't think a lot of the times we elucidate exactly what those symptoms are and what they mean and how we should go about taking an adequate history from a patient regarding the evolution of claudication. Not as many present with back pain, so only about 71% will present with, leg pain, will present with leg or radicular type symptoms, and that has relevance of treatment modalities that are going to be effective for these patients. About a third will present with some form of weakness related to neural compression, and luckily only about 1 in 10 patients will have any sort of urinary or bladder or bowel dysfunction, because that's a fairly poor prognostic factor. Also, which constellation of symptoms they present with will depend on the type of stenosis. So someone who's got lateral recess stenosis is much more likely to come in with leg pain and radicular type symptoms from a single nerve compression phenomenon, rather than someone who's got more of a central canal stenosis, who may come in with axial back pain or claudication. And the axial back pain is often related to the degenerative process at the facet joints rather than the canal stenosis itself. So what is neurogenic claudication? Well, it's essentially a constellation of symptoms that involve pain, tightness, heaviness, and subjective weakness in the lower limbs. It's usually exacerbated by standing or anything that involves extension of the spine. Extension of the spine closes down the foramen on either side and exacerbates neurogenic claudication. Often these patients are actually worse just standing and standing still rather than walking. Certainly it's relieved by flexion, and a lot of people will say if they're doing their shopping or they're leaning over and bending onto a trolley or using a four-wheel frame or something like that, that their symptoms are much better. And classically it's better walking uphill, and they can sit on an exercise bike and cycle without reproduction of symptoms. And that's very important in differentiating neurogenic from vascular claudication. So vascular claudication normally starts in a more distal phenomenon and works more proximally. It's worse with exercise, and it's worse with increasing degrees of exercise. So if you're walking up a hill, you're going to be putting more oxygen demands on your muscles. It's going to get significantly worse, and you do get symptomatic claudication with cycling as well. So that's one of the differentiating features between neurogenic claudication and vascular claudication. So when we're taking histories from these patients, what are the things that we need to know? Well, you go through, and the registrars who will be coming through will use this, and this is what we always use in our Friday meeting, is the decaf thing, and it's a fantastic way to take a focused and accurate history and not forget anything. So the people we're looking at are the 50 to 60 age groups, and it's males equals females, unless they've got a spondylolisthesis. What's their predominant complaint? Well, they primarily come in complaining of pain, claudication, and they may come in complaining of neurology in a particular dermatome or myotome. The associated features that you should look for, and this is true in anything in orthopaedics, you've got to look out for the red flags. And the red flags here are basically tumour, infection, and cauda equina syndrome, and you need to rule these things out. So you need to make sure these patients haven't got features consistent with infection. So they haven't been having fevers, night sweats, they haven't had constitutional symptoms, weight loss, history of previous carcinoma or previous malignancy is very important, because as we know, the spinal column is probably the commonest place for metastatic deposits of distant lesions. And the cauda equina, well, you really want to make sure they haven't had any bowel or bladder abnormalities, they don't have any saddle anaesthesia, and bilateral sciatica or severe bilateral symptoms can often be a precursor to cauda equina. So the associated features is really aimed at ruling out serious pathology. We then want to quantify the amount of impairment or how problematic this is for the patient day to day. I think the easiest way I used to do that is basic activities of daily living. Can you put your socks on? Can you dress yourself? Can you wash yourself? Can you feed yourself? Can you do all of those sorts of subsistence activities? What can you do at home? What are your restrictions at home, and how severe are those? What can you do at work? What can't you do at work? What can you do from a recreational point of view, and how is this impairing you? Do you normally play tennis and you can't do that any longer? And this, I think, is one of the main, sort of really dictates our treatment, is the mainstay of dictating our treatment. And then you want to know what sort of treatments they've had previously. they had any medications, physiotherapy, braces, injections, and certainly if they had any spinal operations previously. So in examining these patients, you use the usual orthopaedic system, but I add walk into look, feel, move and test. I think just about everything in orthopaedics you should make the patient walk. And these patients, they may walk with an ataxic type gait. They may have a foot drop, and you may notice various sorts of gait abnormalities which may point you down looking or focusing your examination in certain neurological pathways. Or often they walk hunched over with a flexed spine to try and relieve the pain that they get by being more erect or upright. So it's important to examine the spine for their alignment overall, examine for any skin lesions, scars, etc., suggestive of previous surgery. Feel, so palpate for focal areas of tenderness. They may have tenderness around the facet joints. They may have paraspinal muscle spasm associated with their back pain, and move, so see how restricted their back range of motion is, flexion, rotation and lateral flexion as well. It's also important to not only examine the spine but also to examine the hip and make sure that they've got no hip pathology that may be masquerading as low back or buttock pain, which is a common thing. It's very important to do a full and thorough neurological examination, so tone, power, reflexes, coordination, sensation, and to compare that to the other side to notice any differences. It's also important to do an adequate vascular examination because these patients can present with vascular claudication, and their back pain may actually be related to an abdominal aortic aneurysm that's an impending disaster for the patient, and that's something that needs to be considered in your assessment. I think serial assessments of these patients for progression is a very important thing. So patients who come back and have got progressive neurology with persistent pain, they're starting to declare themselves as patients that are going to need operative intervention at some stage. It's also important to examine for red flags. So again, the things that you will want to examine for are ruling out tumour, infection and cauda equina syndrome, and along the lines of cauda equina, it may be important to examine for anal tone and saddle anaesthesia. And down here, serious disorders not to be missed. One of the masquerades would be a AAA. Investigation. So, I mean, one of the difficult things is to delineate what subset of patients who present to us with low back pain need to be investigated, and the answer to that is the vast majority don't need investigations. So the reason you would investigate straight up would be patients who come in with red flags. So they've come in, they've got infection, infective type symptoms, constitutional type symptoms. You're concerned about tumour or infection. I think patients who come in presenting with neurology warrant further assessment with an MRI or some other modality, and we'll discuss the investigative modalities. And those that remain symptomatic after 6 to 12 weeks of conservative management. I think patients who present with mildly symptomatic lumbar canal stenosis should be given a 6 to 12 week trial of conservative management of analgesia, anti-inflammatories, weight loss, physiotherapy and these sorts of things, and then told to represent. The vast majority of patients will get better with this type of treatment. And the other reason to investigate is obviously preoperative planning. If you've got a patient that's declared themselves as an operative candidate, then you need to do some imaging to plan your operation. So what investigations do we need? Well, x-rays are the mainstay, and they're certainly the first initial screening investigation. When you look, what are we looking for in x-rays? We're looking for alignment and stability. So is there any evidence of scoliosis or spondylolisthesis related to their degenerative disease? And do they have any instability on dynamic flexion extension x-rays? It's a cheap and readily available investigation. However, it's limited in that it doesn't look at neural elements or any soft tissue contribution. So you can't see how much ligamentum flavum is causing compression. You're just seeing a very basic and gross overview of the osseous anatomy. CT scanning, obviously we all know it's excellent for assessing bony architecture. You get some impression of the soft tissue component, so in the axial you get more of a two-dimensional so you get more of an impression on axial views of the contribution of facet joint and ligamentum flavum contribution to the stenosis, and you can also perform myelography, which allows adequate visualization of the neural elements. The negatives here are, though, you requires an injection of contrast, which isn't without its risks, and it actually has a very high incidence of post-injection spinal headache. So it's a relatively invasive investigation in this day and age. There have been some papers to support CT myelography, however, as being more accurate than MRI scanning, and this mainly related to preoperative planning. And there was a study by Modic who found the concordance between CT myelography and his perioperative surgical findings was 79% versus 77% for MRI scans, so it's neither here nor there. One of the drawbacks is that there is a significant dose of radiation associated with CT scan. MRI scan, well, MRI scan is widely regarded as the gold standard. You get to look at the bone, soft tissue and neural elements. You can accurately quantify the degree of soft tissue contribution to the stenosis, and you get a very good look at the compression of neural elements, and you can then, it's been well described that concordance between radiology and patient symptoms is very predictive of surgical outcome. For example, if you've got a patient who presents with an L5 radiculopathy with decreased sensation on the dorsum of their foot and weakness to EHL, who clearly shows an MRI scan that has a compression of an L5 nerve root on that side, this patient will do much better with surgical intervention than someone who comes in with more patchy neurological findings and some sort of non-focal lesions on imaging. This is obviously also the investigation of choice with regards to infection and tumour, and whilst there's no radiation, it's a much more expensive investigation, and certainly in the public system its availability is limited, and we're usually sort of out to about a 4 or 6 week wait to get an MRI scan. Electrophysiology is controversial, so EMG studies and the like. 80% of patients who have got symptomatic lumbar stenosis will show some form of EMG abnormality. However, a positive EMG supports the diagnosis of canal stenosis and it is helpful in localising which nerve roots are involved. But a negative EMG doesn't refute the diagnosis, so it's still controversial, and I don't think it's still widely accepted as routine investigation in spinal stenosis. So what are we looking for with regards to our investigation? So as we've said, we're looking for these serious disorders and making sure that there's not a life-threatening or serious emergent problem that we need to treat. We're looking at alignment and stability, also looking for any degree of spondylolisthesis. We're looking for the degree and location of the stenosis, and it's been well described that a sagittal diameter of the canal of less than 10 millimetres is highly associated with neurological symptoms, and usually then goes on to require surgical decompression. We're looking at what the contributing factors are, so how much of it is disc, facet joint, soft tissue. We're looking at what degree of neural compression and what neural elements are being compressed. We want to look at the levels affected, because if you've got if you've got multiple levels affected, it's going to affect your possible surgical management, because as we'll get to later into the surgical management, if you fuse various levels, you're going to put excessive stresses at the levels above and below, and if they've got early disease, then it's almost certain that they will manifest as symptomatic disease down the track. And some people would say, if you're looking at preoperative, if in the preoperative setting, some people look at pedicle dimensions if they're looking at instrumenting their fusions. So getting on to treatment, well, whenever you're talking about treatment, I think it's important to know about the natural history of the disorder that you're talking about. And the real landmark paper for natural history of lumbar canal stenosis was Johnson et al. And they looked at 32 patients over 4 years, so not a huge number of patients, but a reasonable sort of follow-up. and they found that these patients were patients with sort of fairly symptomatic canal stenosis who for some reason were either unsuitable for or refused surgery. And they found that in 4 years, without any surgical management, 70% of these patients had unchanged symptoms, so they're exactly the same. Of the patients who did change, half got better and half got worse. So 15% actually improved with no surgical management, and there was 15% that did go on and get worse. So the non-operative management, well, what is relevant non-operative management? So we all know sort of Alan Poppy education, lifestyle modification, physiotherapy, orthotics, pharmacology and injections. What are the good, the bad and the ugly? So the ones that have been proven to be of benefit in lumbar canal stenosis are weight loss. So I think that's something that we underestimate. It's something that really is both easy but difficult. It should be easy, but for our patient population, in my experience, and I'm sure everyone would echo this, that most of them don't really lose weight, but the amount of symptom relief that weight loss can have on any of these osteoarthritic conditions, hip arthritis, knee arthritis, all of these sorts of things, I think is underestimated, and I think it should be one of the first things we discuss with them. And it's also going to make surgical intervention technically easier, it's going to make anaesthetics safer, all of these sorts of things. Non-steroidal anti-inflammatory drugs have been shown to and proven in a number of studies to be of benefit. The problem is the population in which we're talking about often are precluded from using these because of hypertension, renal abnormalities and GI problems. Physiotherapy. So these patients can often get on an exercise bike, and aerobic conditioning has actually been proven to be of benefit in patients with canal stenosis, in addition to further physiotherapy, which involves core muscle and abdominal muscle strengthening. Muscle relaxants have been shown to be of benefit in some studies, but that's usually short-term use because there are negative effects associated with the long-term use, and especially in the elderly population, things like somnolence and balance problems can lead to other medical and orthopaedic issues. What are the bad? Well, braces. There is no evidence for bracing in lumbar canal stenosis. In fact, bracing can be detrimental as it can decondition their core and trunk muscles. If you're putting a brace on and you're allowing the brace to support your spinal column and giving your trunk stability, getting your trunk stability from a brace, it's been shown that the core muscles actually become deconditioned, and it's to the detriment in the long term. Injections, so epidural steroid injections, and there's a good American JOS article regarding epidural steroid injections, and basically the take-home points for that are it's good for radicular and not axial pain. There's a very limited role for an epidural steroid injection in a patient who has not got leg pain or radicular pain. That they should be transforaminal and fluoroscopic guided because that improves the accuracy significantly. They did a number of studies looking at which way the injectate went, so they put contrast in there, injected it either through an interlaminar, a chordal or a transforaminal modality, and they found that a lot of the non-transforaminal pathways, the injectate was actually going to areas away from the nerve root and probably not really infiltrating around the nerve root, and they found that the transforaminal pathway using fluoroscopic guidance was by far the most accurate and should be and is really the gold standard in epidural steroid injection. One of the good things with regards to an epidural steroid injection is a beneficial effect is predicted as a good surgical response. So if you've got a patient who presents to you and they've got left-sided radicular pain and you give them a transforaminal injection and you relieve their pain significantly, they're predictive of having good surgical outcomes down the track because they've got a focal lesion that has been amenable to a temporary relief with an epidural steroid injection, and there have been a number of studies that have supported that. Facet joint injections are another option, and they can be an option if they've got a patient who's got axial back pain. The limitations here are that it's normally not just one facet joint that it's infected, it's a number of facet joints, often at a number of levels, and it's difficult to then go down and inject every facet joint at every level. Facet joints aren't the biggest joints in the body. At the best of times, trying to get a needle in there and inject them is difficult, And if you're talking about a degenerative osteoarthritic facet joint with big osteophytes around it, it's very technically difficult to actually get an accurate injection into the joint to obtain symptomatic relief. So this doesn't project all that well, but if everyone's got their glasses on, this is basically an algorithm to non-operative management. So here you've got a patient who presents with canal stenosis, who has no symptoms. Well, I'm not sure why they'd present then and how you'd know that they came along, but however, obviously, there's no further workup that you do for this patient. For the patient who presents with symptoms, the first step is anti-inflammatories, physical therapy, weight loss, and these non-operative managements, and then re-review the patient. If the patient is unsuccessful to this initial management at 6 to 12 weeks, you can go on and get some advanced imaging studies. So what basically I think the mainstay for us would be erect plain x-rays, AP and lateral, and an MRI scan. If on the MRI scan they've got severe stenosis and they're still symptomatic, they can declare themselves to go straight down the operative pathway. If they've got mild to moderate stenosis, then epidural, and depending on whether they are, their symptomatology is amenable to an epidural steroid injection, that would be the next step in this algorithm. If they're unsuccessful, we again go down to operative. If you're successful, then you institute your non-operative management and keep managing them along that pathway. I think this is quite a good flow diagram for simple management of this problem. What are the operative management options? Well, essentially they all revolve around decompression, because in order to relieve the symptoms of compression, you need to decompress the level. Decompression alone is very rarely performed these days, and the only real indication would be in a patient who's got single level disease with normal alignment, no instability, and minimal degenerative change. And that's almost no patient, because this is a predominantly degenerate phenomenon. Even if you decompress their posterior elements and decompress, do a bilateral laminectomy and decompress their neural elements, you're still possibly going to have pain generators from your degenerative disc and facet joints, etc. So in this sort of situation, really decompression and fusion is the mainstay of degenerative canal stenosis, as distinct from other causes of neural compression in the spine, where decompression alone may be adequate. And really decompression and instrumented fusion is the way things have gone, especially if you're talking about multi-level disease. And there have been a couple of studies which have shown significantly improved union and better clinical outcomes. And you're talking improved union rates from sort of around 75% up to about 95% with instrumentation of your union. And that has actually translated into better clinical outcomes rather than purely just better radiological union. However, you've still got the same patient outcomes. So really decompression and instrumented fusion is the way it's gone today. This also allows you to correct alignment and treat instability. So for patients who have got spondylolisthesis, scoliosis associated with their degenerative canal stenosis, decompression and instrumented fusion is a must. You can't really treat them with anything else. And this is the same sort of algorithm looking at your surgical management. So here, if you've got a surgical candidate, you need to decide whether they've got instability, and indicators of instability are essentially spondylolisthesis, and degenerative scoliosis is also another surrogate indicator of instability in this phenomenon. So if they've got no spondylolisthesis, you can, if they are unstable, so they do have some motion at that segment, then you go on to do an instrumented fusion. If they're stable with no or minimal scoliosis, you can do a decompression only, but as we've said, this is really in the setting of the absence of the other pathologies that we've talked about. But if they do have any sort of other malalignment, you need to fuse an instrument. If they do have a spondylolisthesis, I think it would be a brave spinal surgeon who would go on and decide that this is stable and fuse it in situ without instrumenting. And I don't know anyone that wouldn't do an instrumented fusion for a patient that had a degenerative spondylolisthesis. And that's about all we've got to talk about this morning.